So I'd like to welcome Dr. Sandra Weitz. She is a board-certified anesthesiologist and nationally recognized pain management specialist with over 25 years of clinical experience. She completed her residency and pain management fellowship at the University of California, San Francisco, UCSF, where she later served as faculty and led the UCSF pain service for 5 years. Dr. Weitz went on to build and lead a large multidisciplinary pain practice and now brings that experience to Nevada as one of the owners and founders of the Comprehensive Home Health Solutions. It's a family-owned, physician-owned, and operated home care and home health agency. She is dedicated to improving quality of life for patients with chronic conditions, including Parkinson's disease, through thoughtful, individualized care. So please welcome Dr. Weitz.
Thank you. Really good. So number one, I'm not terribly tech savvy with this new thing, so if I fumble with the slides, you'll know. Number two, I talk a lot, I move a lot. If I say something you don't understand, raise your hand and I'll stop. You don't have to wait till the end, okay? And so Mindy, make my slides move.
Yeah, right. We'll try.
I'm going to open my own slides while she futs.
We did it.
So first off, why should we address pain in Parkinson's disease? Well, first of all, 85% of people with Parkinson's will end up having pain, okay? And pain can be probably the most limiting in terms of your ability to get out and do things and enjoy your life. Probably the biggest reason to talk about it is it usually goes undertreated and under-talked about. It's kind of one of these things where people assume, oh, well, I'm going to have it. I just have to deal with it. And the answer is that's not at all the case, okay? The other thing is that, and show me how you did that.
Just push harder.
Oh, yeah. So I have neuropathy of my fingertips from chemotherapy. I don't feel my fingertips, so when you tell me push harder, my brain goes, what does that mean exactly? So I just want to talk about pain for a second, because we are all trained to think that pain is a symptom, okay? And it means that there is something wrong. And a lot of times that can be the case, right? You have new belly pain, turns out you have appendicitis, you go to the surgeon, they take it out, and your pain is gone. But sometimes, like with chronic pain, pain actually becomes the disease, all right? And we can't always make it go away. And just like high blood pressure, just like Parkinson's, just like diabetes, it is something that has to be actively managed, okay? And so I want you to, as I go through this talk, I want you to think about that, because so often we go to the doctor and we say, X hurts, and they immediately are like, oh my God, it must mean, and the question is there something here that we can improve? Not necessarily, is there something that I need to fix, because not all pain is fixable. So I want to talk a little bit about pain in Parkinson's. And I'm sure all of you understand what Parkinson's does in terms of depleting your dopamine, okay? However, the normal function of the basal ganglia, right? Think of it like a control center. And it's all about checks and balances. And as you have depletion of the dopamine-producing cells, all right, it creates this imbalance. And that is what actually causes the movement disorder. So the tremors, the stiffness, the slowness. But it also changes the way pain signals are sent, okay? And I think that's one of the things that is very under-recognized in treating Parkinson's, because people assume that it's just because of the motor component. But actually, it is really that the signals, the pain signals are being interrupted, and you have this imbalance. So there are a number of different kinds of pain that you can have. So musculoskeletal, pretty self-explanatory, right? Your muscles can hurt, but also all your joints can hurt, because if you think about the body, right? Every muscle that you have is a pulley system. And there's a joint that's connected to it. And then you have your spine, which basically has a bunch of muscles that are attached to your spine that allow you to move. So pretty much any muscle in your body is fair game to hurt. But you can also have pain in the joints, either because of the muscle spasms and the tremors. You can also have it for other reasons, and I'll come back to that in a minute. But you can also have pain from the dystonia, right? Where basically you have these never-ending spasms that don't release. But you also can have something called central pain. I'm going to call on you guys. Anybody have a clue as to what central pain is?
All over your body, maybe? I don't know.
No? Go ahead.
Your spinal cord.
Say that again?
Pain coming from your spinal cord.
No, pain coming from your brain. Okay? And so central pain is basically because you have abnormal filtering of the pain signal at the level of your brain. And so what you need to understand is that if I cut my finger or I touch something hot, there's a signal that is sent from the tip of my finger, ultimately through my spinal cord, to my brain. And my brain then sends back a signal and tells the rest of my body, hey, you just cut your finger or you touch something hot or whatever it is. The problem is that because of the changes in the basal ganglia, your ability to process that signal in your brain changes, and it amplifies the amount of pain that you have. And so people who have centrally mediated pain tend to have pain that is out of proportion to what that signal is. It doesn't mean you're crazy, it doesn't mean you're making it up. So when I tell you it's out of proportion, it doesn't mean that there's something wrong with you. It means that the way in which we process, because we don't have that check and balance anymore, is compromised, okay? And the thing you need to understand is that you can have pain, musculoskeletal pain, you can have pain from dystonia, and you can have central pain that amplifies these other pains. It's not an either or, it's the whole kit and caboodle. And that's part of what is going to make this whole conversation both very interesting, but very difficult. Yep, hold on. Yep.
Too many.
So just a quick picture kind of showing this feedback system. I got it. No, get me back. Next one. So, causes of pain. There are multiple possible etiologies, reasons that you would have pain. So one is just coming from the Parkinson's disease itself, the motor fluctuations, the I'm stiff, I have tremors, and basically, if you understand that, that's the easy part. The other parts are when I am, let's say, stiff or I have spasms, right? It changes your posture. It's going to change how you walk. It changes your gait, right? And if you think about it, all right, Remember that song about the elbows connected to this bone? This is exactly it, all right? If you change the way you walk, then all of a sudden you change the pressure points of different parts of your body. So all of a sudden, you didn't have a knee pain until you had a knee pain because you changed your gait. If you've ever known anybody who's had like a knee replacement, very frequently they come back and they're like, oh, my knee is kind of better, but now I have hip pain. Well, the reason they have hip pain is because when they were walking one way because they had the knee problem, right, they got used to it. Now we fixed your knee, we changed the way you walk again, and then all of a sudden you have a hip pain. And so as your day goes by and you loosen up, you change the way you walk, and you can have all sorts of aches and pains just from the postural abnormalities. Then the other part that I think gets glossed over, if you will, is the fact that just because you have one chronic illness does not mean that you are not entitled to have another or multiple of them, okay? And so, you know, very frequently, and I've been a doctor a long time, so I can say this out loud. Unfortunately, a lot of doctors, particularly in today's day and age, everybody is specialized. There is a doctor for your right thumbnail, okay? And they don't actually think outside the box about all the other parts of whatever they're not treating, okay? And so if you have diabetes and Parkinson's, you are still entitled to have a diabetic neuropathy, right? Which can cause pain. You can still have degenerative disc disease, okay? And I'll talk about that here in a minute. And so, you know, if you have arthritis in the joints between your vertebrae, independent of having Parkinson's, it can cause people very debilitating pain, okay? You can have a radiculopathy, you can have from a pinched nerve, all right? Let's say you decided that you were gonna help your husband move the 300-pound refrigerator that was in the way, okay? And all of a sudden, you know, your leg hurts. Why? Because you herniated your disc, and now you have pressure on this nerve, all right? And that's gonna change the way you walk, all right? And the cycle goes. And so I think one of the things that really needs to be said out loud is just because you have pain, neither you nor your neurologist, all right, need to assume that it's coming only from your Parkinson's disease. You have to really listen to your own body, communicate the symptoms, all right, and we'll talk about that here in a minute. But you have to be able to have somebody help you to see the big picture and you help them to see the big picture. The other thing that I wanted to bring up is injuries, you know, and one of the problems with that stiffness and, you know, the postural issues and the slow movement is you are a fall risk. And God forbid you fall, then we're gonna injure something else, and then this pain cycle just continues, okay? And so I'm gonna get off my soapbox here in a second. But this is the reason that if you are thinking that you should use an assistive device like a rollator, use it. Do not wait, or walking sticks, or whatever it is. Don't wait until you have that fall to decide, oh, I think I need to use something. It is much easier to stay on top of the cliff than it is to fall off the cliff and then try and figure out some way you're gonna get back up, okay? And so injuries can definitely play into that whole pain cycle. I want to take a minute and talk about the definition of chronic pain, okay? The definition of chronic pain is pain that goes on for more than 3 months. And if you have pain that goes on for more than 3 months, the likelihood of it going away is virtually zero, okay? And the other thing about chronic pain is that it ultimately affects you not only physically, but mentally, all right? Because I can't do what I used to do, I don't feel like I used to feel, and the depression that comes along with it, is pretty debilitating as well. And this is why trying to get ahead of this and trying to understand which component is contributing what in terms of my pain is so important. I think you are too far. Is that the next slide? So this is a model of the spine. And I just want to talk about this briefly because so obviously vertebra, there's a nerve root that comes out between every single vertebra and gives feeling to a different part of your arms, trunk, and legs. And then there's a joint between every single vertebra called the facet joints. That's what allows you to lean over, lean back, twist from side to side. And they become arthritic, okay? There's a disc between every single vertebra. That disc is made of jello, literally, truly. And with age, just like jello that you leave in the refrigerator, it gets dried out and it loses its shape and it tends to sag. And that's why most people over the age of 30, if you get an MRI of them, have basically degenerative disc disease, where the disc is thinning, they may have arthritis in the joints, and those can be major pain generators. So as we talk about pain assessments, I want you to understand the spine part of this, because a lot of symptoms cross over among multiple diseases. So first off, a comprehensive pain history. Right? If you come in and say, it hurts, you're not giving anybody any information. Okay? I want to know, where does it hurt? First of all, where does it hurt? How long has it been hurting for? Is it a pain that is continuous? Is it a pain that comes and goes? Is it a pain that's associated with a certain activity that you do? Is it a pain that you have only in the mornings or only when I lay in the bed, right? So the more specific you can be, the clearer the choices of which one of these potential causes is it, all right? Do you have pain? What is the type of pain? Is it shooting? Is it burning? Is it electric? Is it a pressure? Is it an ache? Is it a spasm? All right? The more specific you can be in delineating it, the clearer it's going to be for somebody to go, oh, I need to look at this list of possible causes. All right? Because, for example, if we come back to the spine that I was just telling you, if I lift that 300-pound refrigerator and I herniate my disc and it's putting pressure on my L5 nerve root, I'm going to come to the doctor and say, I have pain that goes down my right leg and it comes from my back and it goes into my butt, it goes down the side of my leg into the top of my foot. That's the distribution of that nerve. If you came in and told me that, I'd be like, oh, you have a herniated disc. I will get an MRI and I'll prove it to you, all right? But the clearer you can be in your own mind in communicating, the easier it's going to be for whoever you're telling your story to try and figure this out, okay? And then I know you're all familiar with the pain scale, right? 0 to 10. It is not 1 to 10. It is actually 0 to 10. You should have 0 pain at some point, maybe when you're an infant. And is that pain, debilitating? How much can you do? What's it affecting you, or in terms of, can I go grocery shopping? Can I go to my grandchildren's baseball game? Can I cook? All right, what can I do? What can't I do? All right, just like I can't push the buttons anymore on the computer, right? It's about understanding, okay, what are the things that are limiting me? Then, so we talked about type of pain, location of pain, duration of pain, okay? And then to really do a detailed physical and neurologic exam. I know that you're getting a thorough neurologic exam for your Parkinson's, but there are many other components, right, to a pain exam than just the pure neurologic part, including What else do you have? Are you a diabetic? If your hemoglobin A1C is, elevated and you have a diabetic neuropathy, then maybe some of your balance issues are actually related to your neuropathy and not only to your Parkinson's, in which case if we do a better job controlling your hemoglobin A1C, all right, your diabetes, then we're not going to eliminate everything, but we may be able to control part of the story. Then, using validated pain scales. I'm not going to go into this in great detail, but there are multiple different scoring systems besides that 0 to 10 that really look at how much your pain is limiting your life. And so somebody who's doing, and this is really more for you to know, if you see a pain doctor or you go see somebody and they are really interested in your pain and really interested in this multimodality approach that I'm going to talk to you about, they're going to do more than just say, oh, on a scale of 0 to 10, how much pain do you have? All right, because that doesn't really tell, you may be 2 right now in the office with me, that doesn't tell me what your life is like. And then, if you are really doing well on your levodopa and you still have pain, then we're doing what we need to do for your Parkinson's, but maybe we're not actually treating your pain. I got it. Nope. So I'm going to talk about multiple approaches. So the non-pharmacologic first, right? You have to move, right? The fundamentals of pain management is to get you off of your couch and moving. The less you move, the less you move. And the less you move, the more you're going to hurt, right? And that's true whether you have Parkinson's or you don't have Parkinson's. Because if you don't move, you're going to get stiff. And if you don't move, those muscles are going to atrophy, right? And I understand that this is a Parkinson's group, but let's just talk about pain in general for a moment. Right? Your muscles are there to help do some of the work. Well, if you don't ever exercise, all right, then those muscles are not really doing any work. So when you ask them to do work, they complain. The other problem is that if you don't exercise and your muscles don't do the work, then your joints have to do more work because you're still moving, right? But then, like for example, if you want to ski and you don't actually do squats before the season, then your likelihood of having more knee pain is that much greater because your knee joint is doing more work because your muscles are not doing the work to take care of you. So physical therapy comes in 2 different forms. And again, I'll get off my soapbox in a second before I even get on it. In the old days, and I am now old, physical therapy was really that the therapist put their hands on you and did manual therapy. Now you go to physical therapy and they give you a home exercise, or they give you an exercise program. It's usually very similar to the home exercise program they're going to tell you to do, all right? And more often than not, it's the PT assistant who's there monitoring whether you're doing it. If you go to a physical therapist, number one, you really want them to do a thorough evaluation and actually touch you, like really measure your strength and really evaluate you. And you really want to talk to them about, are you going to do manual therapy, which includes sometimes massage. It can do passive range of motion that you can't do yourself, particularly if you hurt, all right? A lot of times, you're not going to go beyond a certain point because it hurts. And if you go to a good physical therapist and they do manual therapy, then they can kind of push you that little bit extra that you're not going to go because you don't want to hurt yourself, okay? And then obviously you do need that exercise component. The one thing I will say about physical therapy after many years of sending people to therapy, if you don't do your home exercise program, you can go to therapy from now until the cows come home and nothing is going to happen. All right? Because a lot of times people are like, oh, I'm not making any progress. Well, are you doing your home exercise program? No, I don't know what to do. Okay? not the right answer. If you walk out of therapy, you don't know how to do your exercises, go back and tell them the next time, I don't remember how to do them, or I don't think I'm doing it right, or can you show me again? Then occupational therapy, all right? If you're having issues with your hands, if you have issues with just assistive devices, all right, can't really button my shirt anymore, the occupational therapists are great at coming up with strategies to help you be able to do what you can't do because something hurts you or because functionally you can't. Cognitive behavioral therapy. Every patient I have seen for now 30 years plus, when you say, I want you to go to counseling for cognitive behavioral therapy, almost without exception says, oh, you think it's in my head? No, not at all. However, I can tell you that this gets to you. And I can tell you, and Mindy can tell you, after a year of having been treated for breast cancer, chronic illness wears you down, and it gets to you. And you start to think to yourself, you know what? I'm never going to be me again. And that thought process just fuels that chronic illness. And pain is that chronic illness, all right? And so when you go for cognitive behavioral therapy, it is not to talk about what it was like to be toilet trained at the age of 2, okay? Nobody really cares about what happened before, right? The purpose of cognitive behavioral therapy is to say, okay, we are here today, and we're going to teach you a bunch of strategies for how to cope with where we are today moving forward. And it is incredibly helpful because there are a bunch of strategies to help people deal with the loss of what I can't do, what I want to do, what I used to be, what I'm not anymore, and how, given the fact that I can't do this, okay, let's rethink this, and is there another way to do it bigger, better, smarter, or can I change how I do it? Maybe I don't do this, but I can do that, all right? So if somebody says, hey, I want you to go to counseling, please do not think that A, it makes any less of your symptoms, or B, that you're not going to get anything out of it. At least give it a try, okay? Things like acupuncture, yoga, Tai Chi, yoga, Tai Chi comes back under the category of move. You gotta move. And you have to find which of these you like the best. Some people like yoga. You may have memories of yoga and people in all sorts of contorted positions. I will tell you that there is chair yoga. You can Google it. There are multiple YouTube videos of chair yoga. There's sit and be fit if you are not able. There's my favorite exercise to send people for, and that's aquatherapy. Because in the pool, you are non-weight bearing. It's amazing what you can do. Massage therapy, some people love it and it helps them enormously. The only problem with massage therapy is you actually have to typically go to somebody for it, and it costs money. That's the rate limiting step, in my opinion, of massage therapy, but if you have an acute flare-up, massage can actually be very beneficial. And then biofeedback, typically can be done by a social worker, by a psychologist. Some of the PTs do it. Do you all know what biofeedback is? Does anybody know what biofeedback is? No. Okay, so biofeedback, basically, they will attach you to a machine that either measures your pulse or measures your respiration, and they teach you how to breathe, to lower your pulse and or lower your respiratory rate. And the reason is the idea behind it is it's a relaxation technique. And it can be extremely effective so that, because normally when we have an increase in our pain, right, the immediate response is, and which only sends that signal to your brain saying, oh, wait, we have an emergency, all right? Well, not necessarily, it's just my pain is increased, and so we have to figure out how to de-escalate that. Then, pharmacologic treatments, obviously, I already talked about levodopa, NSAIDs and acetaminophen. So NSAIDs are ibuprofen, Motrin, Aleve. The issue there is making sure that your renal function, your kidney function is normal. Otherwise, those are not really as great an option. Also, those types of drugs, if you take them on a regular basis, can cause gastritis or an ulcer. So, you know, a lot of us are like, including me, have a 500 bottle of ibuprofen sitting on my vanity. I would tell you that if that 500 bottle is not lasting you several months, you should be talking to your doctor about an alternative to it, because the last thing you want is an ulcer in addition to everything else. Acetaminophen is Tylenol. Two things about Tylenol. Number one, it in excess can cause liver failure. If you drink and take Tylenol, it definitely can cause liver failure. And so probably not what many of us want to be doing. You know, and the other thing about Tylenol is you have to be very careful. It masquerades in all sorts of other drugs. So if you're taking cold medicine, it probably has Tylenol in it. If you are taking something like Lortab for pain, which is hydrocodone, it frequently has Tylenol in it. So if your 500 bottle of something, drug of choice is Tylenol, make sure that you're not taking Tylenol in other forms, because that can cause real issues with your liver. Gabapentin, otherwise known as Neurontin. SNRIs are antidepressants. Antidepressants and Neurontin, Lyrica have been used for a long time for pain, okay? And so if somebody puts you on an anti-seizure medicine for pain, it's not because they think you're gonna have a seizure, it's because it stabilizes the membrane on the nerves and it makes it harder for the nerves to send a pain signal, okay? So you have to understand that certain drugs get a bad reputation because we think it's for one thing when it actually does something else. Similarly, the antidepressants, my favorite, Cymbalta, okay? Also used for probably past 15, 20 years for pain, works great for diabetic neuropathies, works really well for neuropathies in general, also stabilizes the membrane on the nerve. So if somebody says, hey, here's an antidepressant for pain, it's not because they think your depression's out of control, it's because they're looking at a multi-pharmacologic way of trying to address this, so you don't end up taking all of that 500 bottle that I was telling you about. Muscle relaxers with Parkinson's disease can be very tricky. You don't always get the result you are hoping for, so they need to be used very judiciously. And then I'm going to say 2 words about opioids. This whole, you know, fentanyl thing that has happened has, among other things, have given opioids a bad rep, okay? And I will tell you that there is an appropriate use for opioids or narcotics in the management of pain. All right, we somehow or another managed to throw the baby out with the bathwater as a society. Now everybody's like, oh my God, you can't possibly give somebody a pain medicine. Okay, except they actually work and there is an appropriate use for it. So if you go to a pain doctor, chances are you're going to have to sign a pain contract, which basically says you're only going to get your pain medicine from one doctor, okay? There is now a pharmacy report that we can all pull up nationwide to see whether you got pain medicine from this doctor and this doctor and this doctor all in the same week. all right? And so a good pain doctor is actually looking at this report. They may actually want to drug test you, all right? And so there are a number of checks and balances that we put in place to make sure that it is absolutely safe and appropriate to treat people. So if your pain is not well controlled, all right, at some point in your journey, and somebody says to you, I can put you on a pain medicine, the knee-jerk reaction should not be no. It's really, how does it fit in my overall treatment plan, okay? And then there's the, okay, I tried the simple stuff, and we're going to move on to more of the interventional type things. So Botox can work very well for dystonia. I've seen amazing results with it. Epidural steroid injections work very well for people who have radicular pain, that shooting, burning electric pain that I was describing to you. Medial branch blocks. Basically, there's a nerve that gives feeling to those facet joints that I was telling you about. So facet pain tends to be that stiff, throbbing, aching. Can be in your neck, can be in your back. It can go down your arm or your leg. And so just for a second, let me explain to you, we'll talk about facet pain in the low back, okay? I already described to you the herniated disc putting pressure on a nerve that gives you the shooting, burning electric pain. The pain that's coming from the joints between the vertebrae in the low back will give you low back pain, but it can also give you this sort of diffuse, throbbing, aching pressure sensation in your leg, all right? And the difference between the two of them, between radicular nerve root pain and the facet pain actually gets worse the longer you sit, okay? And it's the part, if you ever, you wouldn't want to be a pain doctor. If you go out to dinner and I see people get up, all right, the person who gets up out of the chair and is really creaky and has a hard time getting going, all right, more often than not has facet-mediated pain, okay? And it gets better the more you go, because you loosen up, as compared to the radicular pain that comes from the nerve root, and that gets worse the more you walk. So you can, remember 10 minutes ago I was telling you, you got to be able to tell me the story of what is your pain like? This is why. Because if you can tell me it gets worse when I walk, it tells me one thing. If you tell me it gets worse the longer I sit, it tells me something else. The other thing about facet pain is it will, if you have it in your leg, after a while, your leg will feel like you just want to dance, all right? Like if you're sitting too long in a movie or sitting too long in a car and you can't find a comfortable place to put your leg, I'm thinking you have facet issues, okay? So coming back, medial branch blocks. This is a test where we can place a needle and put a local anesthetic at the nerve that gives feeling to each of those joints. And if that pain goes away for the next 4 to 6 hours from that local, it tells me that's where the pain is coming from, and then I can burn those nerves, which is the radiofrequency ablation. It's just done with a tiny needle. It's not a surgery, no back surgery, all right? And it can last a year, 2 years, and it can be repeated, all right? So if you have pain that's either coming from a nerve root or from the facet joints, and not just because of your Parkinson's and the basal ganglia, there are some options that we have to actually make that considerably better. Deep brain stimulation, as we talked about, this is in part, a centrally mediated process. Deep brain stimulation will help the component that is the centrally mediated pain. Deep brain stimulation is not going to do anything for your neuropathy if your neuropathy is caused by something else. It's not going to do anything for your degenerative disc disease. It's not going to do anything for your arthritis. It is only going to do something for your centrally mediated pain, which is why it's important to understand where the pain is coming from. And then spinal cord stimulation is exactly what it says. Instead of stimulating the brain, we're going to stimulate the spinal cord. Typically done after you have failed to get adequate relief. Both deep brain stimulation and spinal cord stimulation, I should say, are the things that we do after we've tried the easier stuff first, because they both involve implanting something and basically are a bigger deal, but can indeed relieve significant pain. So spinal cord stimulation really typically done for people whose pain is primarily coming from their spine, whether it's from the facets or from the nerve root, frequently done after people have had back surgery. And so basically, you need a team, okay? If you haven't gotten in the past 45 minutes that this is really a very complex problem. Even when you don't have Parkinson's, pain is a very complex problem because you have to really figure out where is it coming from and what can we do to treat it. And there are multiple approaches. So you need, obviously, your neurologist, but most neurologists are not pain doctors. And if you're seeing a movement specialist, they're really not pain doctors. Okay? There are some neurologists who have done a pain management fellowship, all right? But most neurologists who are movement specialists have not done a pain fellowship. Psychiatry or psychology depends on psychiatrists. Again, I'm old. Back in the day, the psychiatrists actually used to talk to patients. Now they just write meds. So if you, depending on the team you put together, you may find that the neurologist and the pain doctor may or may not be comfortable with some of the antidepressants. If you have a good pain doctor, they should be willing and able to write for antidepressants as part of a pain management routine, if you will. Counseling, as I said, I'm a strong believer in everybody going to CBT. In my own practice, basically as part of a treatment plan, people for the most part saw the pain doctor, the psychologist or social worker that worked with us, went to physical therapy, usually aquatherapy, all right, as part of a total program. And then obviously PT, OT. It has to be an integrated approach, right? I mean, there's an overwhelming amount of data out there that really speaks to the fact that the best outcomes in the management of pain come from this multidisciplinary, multimodality approach. And I have one more thing to say. And that is, unfortunately, to the best of my knowledge, and I've looked around a fair amount, what I am describing to you does not exist here in Reno at the moment, okay? In terms of a true multidisciplinary, multimodality approach to pain management. And so you are going to have to advocate for yourselves. And you are going to have to work with the people that you have here to put together that team. And I understand that that's hard, okay? But you do not have to live with your pain, okay? Pain is something that is very treatable, right? Can't make it go away, sometimes, but for the most part, may not be able to make it go away, but definitely can get it to the point where it's under control and we can improve the quality of your life. All right, so don't let anybody just say to you, oh, there's nothing I can do about it. That's not the case. On which note, I'm going to open to questions.
So here in the room, anybody with questions, we're going to have you. I'll run up like in the talk shows with a microphone so everyone can hear. And those on Zoom, we have the Q&A box. So please just type in your questions in the Q&A box and we will get to those. So first, any questions here in the room? Yes, I'm going to run to the back of the room.
You guys have to ask questions because I cannot possibly be that clear.
My neurologist had my right leg, left leg was going numb, so they had me do an MRI to see if there was something in my spine. The spine has a curvature in it, and it's got where it's pinching the nerves. Is there anything I can do? I've been to a physical therapist. They give me exercises and to do, but it's not gaining, it's mitigating. It's not mitigating it's still there.
So is your numbness painful or it's just numbness?
Pull my back and it's achy and numb.
Your leg gets numb.
My back. The leg goes numb at certain points in time.
So without seeing your MRI, which makes it difficult, I would tell you that if you have significant curvature that's putting pressure on your nerves, you can go to physical therapy from now until the cows come home, and it's not going to make a difference, okay? Because there's no way that physical therapy is going to somehow change the curvature of your spine to reduce the pressure on the nerves, okay? And so the $64,000 question, if I were you, I would go back and have a conversation with, is this your primary care doctor or the neurologist? This is your neurologist who ordered the MRI, correct? Mm-hmm. Okay. Has he referred you to either a pain doctor or talked to you about seeing a spine person?
The pain, I went to a pain management group, but they wanted to do an epidural.
Yeah. And that's why I'm asking who else you've gone to see, because basically your options are we've got to get the pressure off the nerve, right, or nerves. And so the options for doing that are some type, you either live with it and take medicine to deal with the symptoms, or you do an epidural steroid injection, and the purpose of an epidural steroid injection is to reduce the pressure on the nerve, right? And the way in which it does it is when there is decreased space for that nerve, right? Remember my picture where the nerve comes through a tunnel between the vertebrae. Over time, if that nerve is in a space that's too small, it gets rubbed up against, and you know what happens? It gets swollen. And so what the epidural, what the steroid does is it shrinks the swelling around the nerve, and it can reduce those symptoms for some period of time. That's why they were suggesting that to you. Your other options are potentially to have it surgically, for them to surgically increase the space, all right? And there are a number of ways that can be done. So I think you have multiple options for how to get that better addressed, depending on, and again, how much does it impair you on a day-to-day basis, right? How limiting is it? How well controlled is that pain? Is it something where, boy, it really bothers me every day, I need to do something, in which case it's medicine or a steroid injection or a surgeon? Or it's, it bothers me once in a while and now I know what's causing it and I'm just going to deal with it. That's the spectrum. It bothers you, then I think you got to get happy to talk to you about it more, but I think there are some ways for that to get better controlled.
Other questions here in the room?
Sure.
Yes.
So, I have supposedly arthritis, pretty bad, plus I have Parkinson's. So I had surgery on both my feet. My left foot, I supposedly had a Morton's neuroma. Anyway, so I had hammer, second toe was a hammer toe. Big toe was going to the left. Anyway, doctor went in, straightened them all out. They said, we might have to take out that nerve if we get in there. It's really swollen and nasty. But they didn't. But he stitched me back up. Put a pin in my big toe, straighten out the second toe. Anyway, I was still having a lot of pain even after surgery because my toes would swell up and push on that nerve. And even to this day, even today, I still have some discomfort going on. So it's, I guess the nerve or something's between your second toe and big toe maybe. Mm-hmm. But it comes up my shin and behind my knee. Mm-mm. No, okay. Anyway, that's where the pain was. That's what I kept telling him. And I asked my regular doctor about it. Oh, then I was getting pain in my knee, so I did get a steroid shot in my knee, which helped. But I'm like, it still hasn't gone away. It's a lot better, but it's not gone away. And it's just odd. I mean, it's just, some days I'm fine and other days it's just on fire. But with the Parkinson's, I have clenching too in that foot. So it's constantly kind of, trying to clench. I'm constantly trying to straighten it out. And it's just this ongoing battle, which at the end of the day, sometimes like I just sit down and go, oh my God, this is horrendous, So.
And it's exhausting.
It is, yeah, it is exhausting.
So you're still having pain that goes up your shin?
Yeah, it's odd, really, yeah.
No, it's not odd.
It's a lot better than it was originally.
Yeah, it is
But-
tons better, but it's still there.
Okay, so first off,
Yeah.
the nerve that, when people talk about a Morton's neuroma, that nerve would only give you pain between your toes.
Oh, okay.
As soon as you tell me it's up your leg,
Yeah.
all right, different nerve. Then we're talking about it could be coming from the common perineal that comes out by your knee. It could be coming from your back. This is where trying to figure out where is it coming from
Yes.
is so important, because there's no version of it where it's coming from between your toes,
Gotcha.
up your leg.
Yeah.
Pain goes down, so pain's going to come, if we think as this is the powerhouse,
Yeah.
right? And then what happens then? The signal goes to your spinal cord, and then from your spinal cord, it goes out a nerve, all right? But it doesn't go out one nerve, it goes out through a bundle of nerves.
Yeah.
And then, have you ever been, I'm sure you've been to San Francisco, LA, Houston, these highways that have
Right.
5 different, well actually now here in Reno, right? 5 different exits off of the same big highway, all at the same time. Well, that's basically what's happening
Yeah.
as the nerves come from your cervical spine down into your arm, or from your back down into your leg,
Yes.
okay? And so pain, the point I'm trying to make is pain goes down. Pain does not go up,
Gotcha, yeah.
all right? So pain that you have here
Yes.
has to be coming from a nerve that's somewhere in here. If I have pain in my toe, it's coming from somewhere down here.
Yes.
But as soon as I have pain in my knee,
Yeah.
it's not coming from the nerve by my toe.
Okay.
All right, so, if it's so much better, great. But if it's not better enough,
Yeah.
then you really need to go back and have them reevaluate you and say, okay, great. You fixed my hammer toe,
Right.
right? And it in and of itself is going to have changed the way you walk.
Oh, yeah, tremendously, yeah.
Right?
Yeah.
And so it wouldn't really surprise me that you had other issues in your leg
Yeah.
that get unmasked because we've now changed the way you walk,
Yes.
right? But we need to understand where further up the chain is the problem coming from.
Gosh, okay, yeah.
Okay. I think you had your hand up.
Yes.
I'll come up here so we can hear you.
Doesn't travel very well.
No worries.
Lately, I've been having a lot of bloating, and sometimes it gets so bad in my lower abdomen, it just feels like it's stretching and really severe pain across where I think my intestines would be. Any suggestions for that? No mental pain?
I think the question is, again, I'll come back to what I said at the very beginning. Sometimes pain is a symptom, and sometimes pain is the disease. If you have bloating and you have not been adequately worked up, before I would work on how are we going to treat the pain from the bloating, the first 10 questions would be, change in diet, have I seen my PCP, last time I had a colonoscopy, all of the GI-related questions to rule out that we're not missing something first.
Thank you.
Welcome. Other questions?
Other questions in the room? Yes.
Thank you. Really quickly, Dr. Weitz. When people have pain and it manifests as nausea, how do you figure out where it is?
And the only symptom they have is nausea? again, I mean, I think that really, so nausea can be GI related. Nausea can be vestibular, all right? Balance if you have vertigo. Nausea can be anxiety. Nausea as a symptom is so nonspecific. It can be so many different things. And this is where, really, so I'm a big fan of keeping a diary and journaling. All right, am I nauseous every day? Am I nauseous only on Tuesdays? Am I nauseous when I eat something specific? Am I nauseous when I drive in the car with my husband, especially around the Tahoe curves? All right, what is the nausea related? Can I find a pattern? All right, because that will often give us a clue. Is it that you have issues with your eyes? When was the last time you had your eyes checked? I mean, I think it's really understanding, okay, it's so much as pattern recognition and then ruling out the most likely things first and then working your way down the list. Yeah.
Thank you. Other questions here in the room? Yes.
Yes, I have a question about the medicine. I take my last pills usually around before dinner time, and I don't take any at night because I sleep very well. When I get up in the morning and my back's killing me. So is it likely that I should take a slow release levodopa or something to help it feel better in the morning?
Yeah, so one of the things, that's actually a very good point. And that is really understanding for every drug that you take, not only your Parkinson's meds, but every drug that anybody takes, the half-life of the drug. How long is the drug really supposed to last? Because that will help inform you, when you should take your meds, but B, more importantly, when to have the conversation about a long-acting medication, right? Because a lot of the times, especially for things that we take more than once a day, right? You do what I would describe as riding the roller coaster. It works, it wears off. It works, it wears off, okay? And you're always playing catch up. And so if you wake up in the morning and you're hurting, right, by the time you take your pills in the morning and you feel better, we're halfway through the day, right? And so I'm a big fan of long-acting medications in general because it really eliminates. It's much easier not to play catch up, especially with pain. Once you get behind the pain 8 ball, all right, it is very hard to get ahead of it. It's the same reason that if somebody has an operation, we tell them take the pain medicine before the pain gets severe. Don't wait, all right? Even if you take ibuprofen, it doesn't work until like 30, 45 minutes. So by the time you're thinking, oh my God, I really need to take something, I'm really hurting, you still have a period to go. And so, yeah, I would definitely, if you're taking your pills at 6 or 7, and then nothing until you get up in the morning, and you're not on a long-acting, no, that does not surprise me that you're miserable. But as I said, I mean, I think it's an important message about every single drug you take to understand when to take it and how long it's supposed to last. And some medicines we say, oh, it lasts 12 hours, except it doesn't really last 12 hours. It really only lasts 8. All right? And I don't know why we think we're fooling somebody. The other thing about it is understanding we as physicians are very guilty of writing once a day. Nowhere in there does it say when during the once a day are you supposed to take it. And there are some medicines, including some of the high blood pressure medicines, that can make you very dizzy, that we really, or feeling kind of tired, that we really should be telling you, take it at night, because you're going to go to sleep anyway. Instead of once a day, and people say, oh, I'm just going to take it in the morning, and then they're dragging all day. All right, so if somebody gives you a once a day, say to them, when is the optimal time for me to take this? instead of just going, okay, fine. And the other thing, coming back to your question, and that in a way, and that is about consistency. If you are on meds, take them the same time every day, especially the long-actings, right? Because if I take this drug today at 8 a.m., and then tomorrow I take it at 2 p.m., well, it's not really 24 hours, it's now more like 30 hours. And then when I take it the next day at 6 in the morning because I'm going fishing, all right, it's not really 24 hours, it's not, you can see where I'm going, right? The times are doing the accordion thing. And so you've shot yourself in the foot, all right, just by not being consistent. So whatever you're gonna take, have a routine. It's also the way to not forget your pills, just as an aside. Other questions?
Anything else in the room? And for those on Zoom, I'm not seeing anything. Any questions on Zoom? I'm not seeing questions in the room or on Zoom. So with that, I would love to say a huge thank you.
My pleasure.
Something else?
No. You can get a hold of me if you always after the fact. Everybody leaves the doctor and says, oh, I should have asked. This is how you can get a hold of me. I'm happy to answer any questions.
And that is
Okay.
also on the handout that you have. And for those on Zoom, we will be emailing out that handout, so you will receive that. Actually, everybody here in the room will also receive it electronically because I just put it all in one big list.
Get out of your way.
With that, thank you so much.
Thank you.
Applause, applause.
Thank you.